folks joining today, where you can tweet about the presentations happening live and use the tweet the hashtag Trainee Blitz. And if you're not already following us, you can toss us a follow on Twitter, Facebook, or Instagram. We also always appreciate donations. So like I said, we can't do this work without the help of sponsors and donations. So there's that link if anyone's interested. And without further ado, we'll get going. So I'm just gonna stop my share and we'll get our first presenter, Victoria, to get her slides up, and I'll just read her bio. 1 second. So Victoria is a second-year MSc student at the Cummings School of Medicine at the University of Calgary. Under the supervision of Dr. Sophia Ahmed. She recently graduated with a Bachelor of Nursing and is a registered nurse. Victoria's research focuses on quality of life of individuals initiating hemodialysis and understanding the potential sex and gender differences in this population. And yes, we'll be about 5 minutes for the presentation and then a few minutes for questions. So if you can hang on to your questions, you can either type them into the chat and I can read them out, or I think you can just go ahead and unmute yourself. And if not, just raise your hand and I can unmute you. So with that, I'll welcome Victoria.
Thank you for that introduction, Alex. I will be presenting on my project today that's looking at the association between sex, gender, and hemodialysis type. So just for some background, people with kidney failure require kidney replacement therapy, such as hemodialysis or survival. And essentially, hemodialysis is when you are connected to a machine that filters and removes the toxin from your blood and takes on the roles of the kidneys. Typically, hemodialysis is 3 times a week for 4 hours each session, usually done in a hospital or clinic setting. And this is referred to as conventional hemodialysis. And this is kind of the standard hemodialysis prescription. However, with conventional hemodialysis, literature has found that women on this treatment have a reported lower quality of life compared to men receiving the same treatment. And women actually have shown to have better survival when receiving more dialysis. So in Alberta, a new hemodialysis prescription called incremental hemodialysis has been employed, and it's a potential way to improve quality of life. So it is less than 3 times a week, so it can be either done once a week or twice a week, but it is anything less than 3 times a week. So overall, sex and gender are not taken into consideration when prescribing dialysis. Therefore, my objective is to determine the association between sex and gender score with quality of life and stratified by hemodialysis type. For my PCOD, my population is incident kidney failure patients that are initiating hemodialysis all across Alberta. My exposure is incremental hemodialysis and will be compared to conventional hemodialysis. My outcome is quality of life, and it's measured using the Kidney Disease Quality of Life 36-item questionnaire. Sorry, that's a mouthful, but it's referred to as the KDQL. It's a valid and reliable tool in this population. And the study design is a prospective cohort study with a 3-month follow-up period. So again, the KDQL is used to collect a quality of life score. However, the scoring, you don't get like an overall quality of life score out of 100. The questionnaire is broken down into 5 components, looking at different aspects of quality of life. For my project, I look at the mental component and the physical component, or the MCS and the PCS, as the literature has shown that after 3 months, if there is any increase or decrease by 1 point in the score, it either increases or decreases mortality by 4%. So having any 1 point change is kind of significant after 3 months. So in order to analyze gender and get a gender score, the Genesis Proxy Gender Questionnaire was used. And again, these tools were administered at baseline as well as at 3 months. So at the start and then at follow-up. But the gender score questionnaire doesn't just look at gender identity. So it takes into consideration gender roles, gender norms, and gender relations. And for this, you do get an overall score out of 100, where a higher score is indicative of greater femininity, which based on the questionnaire refers to having more roles and responsibilities towards the household or to caretaking. And then a score closer to 0 indicates greater masculinity, which just means less roles and responsibilities towards the household. So from table 1, this is the baseline demographic information. There's kind of a lot going on because I broke it down by the total sample as well as dialysis type and then by sex. All participants were cisgendered. So in the results, I just stuck to biological sex and not gender identity. There was a total sample of 44 with 20 on conventional and 24 on incremental. And there was a higher percentage of females on incremental compared to conventional. For age, it was similar for females on both dialysis types. However, males had a higher age at 71 when starting incremental compared to 58. So there was a huge age difference, although not significantly different. eGFR, it's a measure of kidney function, and usually dialysis is started when an eGFR is around 5 to 8. And for this population, it was around 5 to 7. And 24-hour urine is a measure of residual kidney function and is actually used to determine eligibility for incremental. So you need to have higher kidney function or better working kidneys in order to receive less dialysis. So interestingly, males had a higher 24-hour urine on conventional dialysis compared to incremental, which you would expect to see the opposite, but you do need greater than 600 mils to even be eligible for incremental. And none of these results were statistically significant, but interesting to see. So I then analyzed the difference from 3 months to baseline in both the MCS and the PCS scores for the quality of life questionnaire. This is the conventional dialysis group, and I'll go through the incremental on the next slide. It's just easier to see this on one big slide. So you can see that both males and females had an increase after 3 months on both the physical and mental health scores. However, males had a greater increase, and these results were not statistically significant. So for the incremental group, both males and females had a decrease in their physical health, and females had a greater decrease in their physical health. When looking at the mental health, they both had an increase after 3 months, although it was 0.1 and 0.8, so not a huge improvement after 3 months. And again, these results were not statistically significant. I then created a graph to show the distribution of the gender score by hemodialysis type as well as by sex, just to see where they lied on the gender score scale out of 100. So again, on the far end here is masculinity, and on the greater end indicates femininity. So you can see here that basically all dialysis types are kind of centered around the lower score end, which indicates greater masculinity. However, it's interesting that only females on incremental, so females receiving less than 3 times a week, are the highest proportion that has a higher gender score compared to the rest. And then females on conventional, so the females receiving 3 times a week dialysis, don't even go above 70. So they all are centered around the lower, towards a masculine gender score. So overall, sex is not associated with quality of life and hemodialysis type, and gender score appears to be a predictor of hemodialysis type. And it's important to understand the effect of sex and gender on hemodialysis in order to improve outcomes for people living with kidney failure. Thank you for listening. Are there any questions?
That was awesome. Thanks, Victoria. Super interesting. I think you presented about a year ago or so it's great to see the progression of the project.
Yeah, I'm just gonna stop sharing.
For sure. Does anyone have any questions at all?
I had to speed through. There was a lot of results to get through.
No, it was great. One thing I just was curious about, so you said gender was more of a predictor of hemodialysis type? That's interesting. Yeah. So I would have thought it would have been sex, because if it was more biologically based, but.
Yeah, so even though it wasn't statistically significant, it looks like gender score, so more the gender roles in your household and gender relations play more role in your dialysis type. So if you are the primary person responsible for household, you might want to be on incremental and have less time on dialysis. And the way that the score, how you score with the Genesis proxy, it's kind of a yes, no. So if you're not the primary person, it means you're on the masculine end for household, for caring for the household, which if you're sick and you have kidney failure and you're not feeling well, that might shift in your household. So your partner might then pick up the primary household or caretaker role. But then when you score, that just means you have a masculine gender score. So a lot kind of plays a role with that.
Yeah, it's fascinating. Just leave it open for one more second here if anyone has any questions. All right. Well, wonderful presentation, Victoria. Thank you so much. Nabilah, I'll get you to share your screen. I'll just read your bio here. So our next presenter is Nabilah Gulamhusein. So Nabilah is an MSc student all at the Cummings School of Medicine at the University of Calgary. She recently graduated with a BSc in Biological Sciences from the University of Calgary. Her research focuses on the root of postmenopausal estrogen administration and cardiovascular risk. Nabilah hopes to become a leader in women's cardiovascular health research and improve patient outcomes. So with that, I'll welcome Nabilah.
Okay, can everyone hear me?
Yeah.
Perfect. Okay. So thanks for that introduction, Alex. So I will be presenting on my thesis proposal, which is the root of postmenopausal estrogen administration and cardiovascular risk. So to start off, what is cardiovascular disease? So cardiovascular disease is an umbrella term used to describe conditions that affect the circulatory system, which includes the heart and blood vessels. Cardiovascular disease is the leading cause of death among women, not only in Canada, but also worldwide, which highlights the need to find female-specific cardiovascular risk factors. So previous studies have shown that exogenous forms of estrogen are associated with increased cardiovascular risk and vascular events. So it's thought that this might have to do with how a drug enters circulation. Perhaps increased risk occurs because oral forms of estrogen are subject to first-pass metabolism while non-oral forms are not. So first-pass metabolism is when a drug is taken orally, and then it enters the digestive tract and then goes to the liver, where the bioavailability of the drug is drastically reduced, and then it's allowed to enter circulation. Alternative routes of administration, such as intramuscular or through the skin, bypass the intestines and the liver and directly enter circulation. Overall, there are only limited studies that hint at this relationship between route of estrogen administration and cardiovascular risk, and they're really low quality observational studies. And overall, it remains unclear if route of estrogen administration in postmenopausal females is associated with cardiovascular risk. So that's what my research will be focusing on. The goal of my study is to determine the association between the route of estrogen administration and measures of cardiovascular risk. We hypothesize that oral estrogen compared to non-oral forms of estrogen will be associated with greater cardiovascular risk. So to briefly go over the study specifics, the population that I'll be looking at is postmenopausal females less than 60 years of age. The exposure is individuals who are going to be on oral forms of estrogen, and they will be compared to individuals on non-oral forms of estrogen. This is going to happen through a cross-sectional study, and my primary outcome is mean arterial pressure, also known as MAP, and my secondary outcomes are arterial stiffness and renin-angiotensin-aldosterone system activity. So mean arterial pressure is the average arterial pressure throughout one cardiac cycle. It's measured as 2 times the diastolic blood pressure plus systolic blood pressure divided by 3. So an increase in mean arterial pressure indicates an increased cardiovascular risk. The next outcome, which will be measured, is arterial stiffness, and this is measured by something called pulse wave velocity. So pulse wave velocity is measured through the use of ultrasound probes placed on the surface of the skin, particularly on the carotid artery in the neck and the femoral artery in the groin, and the amount of time that it takes for blood to travel from the carotid artery to the femoral artery is measured and is used to determine arterial stiffness. So the greater the time it takes for blood to flow, the better, because that means that the artery is elastic and healthy, whereas a shorter time indicates that the arteries are stiffer and thus there's a greater cardiovascular risk. The last measurement or outcome measurement is RAS activity. So RAS is a system in the body which maintains blood pressure by controlling blood volume. Angiotensin II is a component of RAS and ultimately helps increase blood pressure in a variety of ways. So when an individual comes into the lab, we give them an angiotensin II infusion and observe their response. We expect that when we increase angiotensin II, that there will be a spike in blood pressure through these variety of ways. And if we see no or minimal response to the angiotensin II infusion, this suggests that the individual has an increased cardiovascular risk. So to briefly go over the study methods, first, we're going to recruit individuals from pharmacies and OBGYN clinics across the city of Calgary. And then we will enroll individuals once they express interest. And at this point, we will screen for eligibility and obtain their consent. Then on study day, we will collect their information such as age, self-identified race, the type of estrogen that they're taking, and we will obtain their outcome measurements, so blood pressure, pulse wave velocity, and RAS activity. And then lastly, we will analyze this data. So last but not least, why is it extremely important that we should do this research? So more than 60,000 women become menopausal daily. It's estimated that by the year 2025, there will be 1 billion individuals who are menopausal. 80% of these individuals will experience debilitating vasomotor symptoms, such as night sweats and hot flashes, which may be alleviated by the use of postmenopausal hormone therapy. Results from this study will help us better understand cardiovascular disease and its risk factors, and will allow individuals and their healthcare providers to make informed choices. And lastly, I'd like to acknowledge my lab for supporting me in my research process, and I will take any questions.
Fantastic presentation. All right. You can either type questions in the chat or unmute yourself. I have questions always. I was curious, are you going to be like breaking down different types of estrogen, like say like vaginal versus transdermal? Because I don't even know if like some of the literature is still a bit murky around like how much, say if you're just administering it vaginally, like how much of it enters like the general circulation. But yeah, I was curious if you're going to break that down at all.
Yeah, so depending on like the type of people that enroll in the study, if we do have like a big divide between like individuals who are taking vaginal forms or intramuscular or transdermal, then yeah, we're definitely going to like be stratifying the analysis to ensure that we're like comparing the different types of estrogen exposures. But I mean, it's very possible that we only get like only individuals on vaginal creams, because that is like one of the most common types of estrogen administration.
Mm-hmm. Yeah, I hope you get enough to break it down, because that'd be
I hope so.
This is a great project.
Yeah.
Leave it 1 more minute there. Okay, well, thank you so much. That was really, really interesting. I hope you come back and share your results with us when it's all wrapping up.
Thank you.
Okay, so next up we have Hallie. So Hallie, you can share your screen. So Hallie is a PhD student and Canadian doctoral scholar at the School of Population and Public Health at the University of British Columbia. Hallie previously obtained her MPH in maternal and child health at the George Washington University, where she researched the impact of the Liberian Civil War on maternal and child health. Prior to starting her PhD, Hallie worked at the University of Washington and the UBC Faculty of Pharmaceutical Sciences. Hallie's research experience includes cervical cancer, colorectal cancer, breastfeeding, contraceptive, and mixed methods research. Currently, Hallie is working under the supervision of Dr. Gina Ogilvie to understand the social and economic impacts of cervical cancer on women and children in Uganda. All right, go ahead, Hallie. You might be on mute.
Sorry, you think I'd never done this before. Hold on.
Okay.
Okay, hold on.
That's okay. Take your time.
Okay, let's try this again. Can we hear me?
Yeah, sounds great.
So hi, everyone. My name is Hallie, as Alex said. I am a PhD student at the University of British Columbia. And so today I am going to be presenting on my doctoral research, which is a protocol, and it's gaining an understanding among mothers and children of the social and economic impact of a cervical cancer diagnosis in Uganda. So cervical cancer is actually a leading cause of death in low and middle income countries. And I think people find that surprising, considering, there really are large spread screening methods and prevention methods for cervical cancer. I think, we're really all familiar with things like the pap smear and, most recently the HPV vaccine. And while, we know a lot about things like the physical impacts that a cervical cancer has, and maybe the emotional impact that a cervical cancer has, not a lot is known about the social and economic impacts. And so what I mean by that is things like stigmatization. We know that cervical cancer is a largely stigmatized disease. How it changes impacts with maybe a woman's familiar relationships with her husband, but even those impacts also with her children. So how her children are faring in their education, whether they're having to drop out of school and maybe take a job, which would apply to economic impacts, whether women are also dropping out of work because of their treatment. And my research specifically is going to be focusing on Uganda. In Uganda, the Uganda Cancer Institute is the central treatment center in Uganda. And even though, treatment in theory is free in Uganda, many women actually report having to pay out of pocket for those treatments. And not even, necessarily just the treatment, but considering there's really only one place to get treated in Uganda, it's a pretty big country. Whether women are having to travel and pay to travel across country to get treated, whether they are also whether taking time off of work, and then also, including those indirect, like whether they're having to stay at someone's house as well. So the goal of my study is to understand the social and economic impacts of cervical cancer on women and children in Uganda. So my study is going to be mixed methods, and I'll use the triangular design to conduct it. We're aiming to recruit approximately 350 women who are being treated at the Uganda Cancer Institute in Kampala. And the goal is to recruit women over approximately a 4-month period. And these will be women who come in, they have appointments at the UCI, and we'll recruit them straight from the waiting room. The data collection will be broken down into 3 different parts. So all women who are recruited will be asked to complete about a 45-minute or so survey. It's about 68 questions. And it has really a widespread variety of questions, including the basics like demographics, what kind of cancer treatment they're receiving, but also, scales on the impact of their relationships, particularly with women and children, with their children and their husbands, as well. Also impacts on their children, whether their children are dropping out of school. There's a section looking at household impacts as well, looking at whether they're increasing their chores, decreasing chores, whether children are increasing chores. And after that, each woman will select approximately 10 to 20 women to complete a mini interview. And these will be about 3 questions that we ask women. And it's really just to kind of dig down deeper onto those impacts in children. One of the unfortunate things is that even though we're looking at the impact of children for this study, we're actually not able to recruit any children. So we're hoping the interviews will kind of flesh that out a little bit more. And then finally, we'll do a chart review on all women. And this is really just to confirm things like their cancer stage, what kind of treatments they've had to date, how long they've been in treatment. So all the data will be collected by a research assistant, a Ugandan research assistant. We decided to collect all of the data orally, and this is just because of literacy rates in Uganda. We realized that not everyone is going to be able to read and write, so just for consistency, all surveys will be done orally. We're going to collect them in RedCap on iPads and then upload them at the end of each day to the internet, or I guess the server. And like I said earlier, it's going to be done over a 4-month period. In terms of the analysis, we'll run bivariate and multivariable regressions, looking at a lot of those quantitative variables that I previously mentioned, particularly the scales. In terms of the qualitative analysis, we'll be using a thematic analysis just to look at those significant themes. And so really, the impact of this is really going to be the first survey to, not only look at this in Uganda, but really look at a lot of these measures in any kind of low and middle income country. We're looking at things like catastrophic health expenditure expenditure. So comparing how much women are spending to how much their income is, and comparing that ratio. Looking at the impact on children, and looking at those relationships within the family and then the greater social structure as well. And the reason why we're really all doing this is we really want to advocate for the expansion of cervical cancer screening, not only in Uganda, but other low and middle income countries as well. And the overall goal, of course, with this is to eliminate cervical cancer worldwide. And thank you very much.
Awesome. Great work, Hallie. That's going to be an incredible project, and 350 people, that's going to be a hefty number of survey responses. So yeah, great work. Does anyone have any questions? You can type them in the chat as well. I guess that was going to be my question. You kind of answered it at the very end, though. I was like, so what do you see this, like, what sort of policy change would you want to see based on these findings, like for Uganda, just scaling up more prevention efforts? Or
yeah, the overall goal is to expand screening. And I mean, I think the lucky things for us, particularly since we're partnered with UCI, is that, every 3 to 5 years, Uganda revisits their screening guidelines. I think they last did it, I believe, last year, and they're kind of finalizing the current report. But really the hope for this is to kind of, for the next round, provide even more data. And, I think a lot of the impacts they're looking at these days are kind of the direct impacts, like health on women, how many people are being screened. But the hope with this study is to be like, look, there's all these other direct impacts. It's not just impacting women who are diagnosed, but it's impacting their children, their family. It's even impacting the economy.
Yeah. Is the screening mostly still done by pap smears there as well?
That is a really good question. There's a lot of different methods, I think. And I think some of them are like things, I actually don't. Actually, I'm going to be honest, I don't know.
I was just being curious.
It's not really much.
Yeah, cool. Great project, though. I'll leave it open for one more minute for anyone that has a question. And if not, thank you so much, Hallie. That was awesome. Great work. Okay, so next up, we're going to have Jennifer. So Jennifer, if you wouldn't mind sharing your screen. So Jennifer is a PhD candidate in the Department of Kinesiology at McMaster University. Her present research focuses on the short and long-term impacts of hormonal contraceptives on cardiovascular outcomes in females. And she has recently pivoted her research to look at the underlying mechanisms of contraceptive hormones in vascular endothelial cells. Committed to the advancement of women in STEM, Jennifer volunteers with McMaster Women in Science and Engineering Group, is a graduate trainee with the CIHR Institute of Gender and Health, and also teaches on the topic of sex and gender and health at McMaster. She's excited to share her current PhD research progress and hear of other women's health research from the WHRC trainees. Welcome, Jennifer.
Much, Alex, and I apologize if my internet does go out. I'm just getting an unstable internet situation at my end, so hopefully we'll be able to get through the next 5. So today I'm very excited to be presenting on a proposal project. We're actually about 2/3 of the way through collection on this project, so I'll be excited to bring some results to the trainee network in a couple months from now. We're looking at the acute effects of emergency contraception on vascular health. So I'll provide a bit of background first before jumping into what we're up to. So in my research lab, we look at vascular health from the perspective of looking inside of major conduit arteries. So for example, the brachial artery in the arm. And what we see here is a schematic of the artery. We have endothelial cells surrounded by vascular smooth muscle. And we know that endothelial cells are really important for generally vascular health. They help to expand arteries in response to a shear stress or blood flow stimulus that I'll show you in a moment. In our lab, we also look at endothelial function, smooth muscle function, stiffness of our arteries, which I'll share in a moment, as well as cerebrovascular function going to the brain. So this is a cross-section of an image, ultrasound image of an artery. And you can see here that those thin lines right about here is the endothelial cells and surrounding smooth muscle around it. So this is what I get to look at every day in my lab. So one of our main tests that we run in the lab is an endothelial function test. And essentially you see this cross-section of the artery. We take a baseline image using an ultrasound machine for a period of a minute, and then we inflate a cuff for a period of 5 minutes. And what this does is it causes distal ischemia, the buildup of metabolic byproducts, such that when we deflate the cuff, there is a rapid increase in blood flow that you see there on the screen. And what that does is it increases the size of the artery. And the idea here is that by looking at how much the artery dilates or expands in response to the shear stress stimulus, that can tell us information about how healthy the artery is. And that is an indicator for future cardiovascular disease risk. Another thing that our lab looks at is arterial stiffness. Now we know that arterial stiffness, how stiff our arteries are, which we've learned about previously today, is associated with increased risk for cardiovascular and cerebrovascular conditions. So a very elastic artery, as blood flows through the artery, would expand and be more compliant, be stretchier in response to blood flow. Whereas a more stiff artery would not be as compliant and would send blood faster through the artery. Thus, a pulse propagates faster through an arterial tree. So we look at a couple different areas of the body for arterial stiffness. We take measures of peripheral stiffness down the arm, central stiffness across the main portion of the body, and peripheral stiffness in the leg. Central stiffness in particular has been closely associated with the development of cardiovascular disease conditions. And then stiffness of just the carotid artery is also very closely linked to cerebrovascular condition development. So with that background in mind, we're presently looking at the influence of emergency contraception. And we know that about 1 in 10 sexually active women have used an emergency contraceptive. And the reason why I'm so interested in this is that rate is increasing. So you see here, about 25 years ago, maybe at about 1% of sexually active women were using emergency contraception. That's gone up quite drastically in the last couple of years. And now there hasn't been more recent data than the late 2020 or 2010s, but it looks like this trend is increasing. And so with this information in mind, there's very little that we know about how emergency contraceptives acutely influence the cardiovascular system. So what is emergency contraception? Emergency contraception is a 1.5 milligrams synthetic progesterone called levonorgestrel. It is a common progesterone that's also found in an oral contraceptive pill type. That is, a smaller amount of this progestin is found in oral contraceptives. And we found in our research that these oral contraceptive pills containing levonorgestrel may be associated with negative vascular health indicators, particularly endothelial function, decreased function, as well as increased central arterial stiffness. So the idea here is that if we have an oral contraceptive pill containing levonorgestrel influencing the cardiovascular system more chronically, could we also see that levo would acutely influence the cardiovascular system with this ultra large dose through an emergency contraceptive? So this study is currently examining the acute impact of emergency contraception on vascular health, as well as some underlying cell mechanisms that we're exploring. And it will be the first study to address this knowledge gap in our understanding of the influence of emergency contraception and the cardiovascular system. So in terms of our study design, we have folks come in, they rest supine with us, and then we take some baseline hemodynamics, heart rate, blood pressure. We then do a blood draw because we're going to be looking both at the hormone levels before and after taking this pill, as well as we do some cell-based exposure where we take the serum from blood and expose it to endothelial cells to look at different mechanisms that may be underlying the response. We then take measures of arterial stiffness like you see here, where we're measuring central stiffness. We take a measure of endothelial function, again, using that cuff test I explained. And then individuals will sit and take the Plan B pill. And then we do it all over again an hour and a half later after the serum levels, so blood serum levels of levonorgestrel reach their peak about an hour and a half after taking the pill. And then we redo all of our measures post in order to look at these acute effects. So that's currently what we're interested in, what we're exploring. I'd be happy to take any questions, and I'm very open to ideas as we're currently in the midst of data collection.
Thanks, Jennifer. Great presentation. Any questions? Gotta be one. One person has to ask a question by the end of this.
I have a question. This is Sophia. So hi, Jenny. It's nice to see you. So
You too.
they're a great presentation. That was lovely. You do such amazing work. So I had a question. So like, how will you bring people in? Like just how, can you just walk me through your recruitment process? As you know, recruitment is the hardest part of all clinical research. So just for some tips. Thanks.
It's interesting that you mentioned that, because when we first got started with the project, emergency contraception comes with some stigma in terms of use. And I think some folks were not as excited at the beginning in taking the pill, but actually I have seen a pretty drastic increase in our recruitment efforts just in the last couple of weeks. People are interested in exploring how this affects their cardiovascular system. So what we do is we put up posters and we recruit throughout the university community and surrounding community. And I've had about 25 folks reach out and we book them in, and we're about 2/3 of the way through those data collections. So our end for this study is 20. So it's not a particularly large study, but it will be exploratory in terms of its nature. Yeah, but I was initially concerned at first as well about just knowing some of the stigma that exists around contraceptive use, but it hasn't been as much of an issue as I initially anticipated.
That's amazing. Well, congratulations. Look forward to the results.
Me too.
Anyone else? I was wondering, do you know approximately how long, so the dose lasts for? Like, how long would you expect that acute effect to last for?
Yeah, it's a good question. So the serum levels, so we're going to see an increase in the serum levels in the blood till about an hour or two afterwards, and then it starts to taper down. I believe the half-life is about 12 or so hours. So most individuals will see that it drops off after about 2 days or so in terms of, I think it's like 5 half-lives, and then it's out of your system for the most part. So yeah, I would expect to see that. In terms of symptomology, some individuals might experience side effects. That usually goes for about 2 to 3 days, and then it tapers off from there. So yeah, I think from an acute perspective, we were most interested in looking at what we could do well in the lab, 2 hours at its peak to see the most acute effects. But I would be genuinely interested in exploring, 24 hours later, what's happening in the body as well. But this is definitely a first step in the process.
Very cool. So I suppose somewhat like the exploratory nature of it could potentially be lay the groundwork for more like the long-term effects of like other progestins and stuff like that. But is that sort of maybe laying the groundwork? Am I getting that right? Or
yeah, exactly. So another big part of my PhD right now is we're exploring different contraceptive hormones and looking at acute and chronic effects of those. But this is one of the only models where you're looking at just progestins alone, which is a really curious model, and an ultra high dose of this. Like this is 10 times the amount that would be found in an oral contraceptive pill, almost 40 or 50 times that of typical like IUD use. So quite a high dose of progestin. So I think it's neat from that perspective, from both like a basic biomedical perspective, but also from like a 1 in 10 females are using these pills. And so we need to find out what's happening in the body.
Wonderful. Okay, let's leave one more second if anyone has any questions. Everyone's just saying great study, looks really interesting. Okay, sounds good. Well, thank you so much, Jennifer. And so last but certainly not least, we'll have Grace up. So Grace, you can go ahead and share your screen. So Grace is a second-year MSc student in reproductive and developmental sciences program at the University of British Columbia. She earned her BSc in chemistry with a concentration in biochemistry at Haverford College back in 2017. Her current research focuses on the role of mental health history across reproductive age in understanding risks associated with perinatal depression and anxiety. Welcome, Grace.
Thanks, Alex. Just trying to find the unmute button. Yeah, so thanks for that introduction. Yeah, my name is Grace, and I'm going to be presenting my thesis work so far, at least the first kind of section of it. So looking at the role of depression and anxiety profiles in predicting pregnancy and birth outcomes. And so to give you some background, there's an incredibly high prevalence of depression and anxiety within pregnancy. So it's estimated to be about 18.4% for depression and about 15.2% for anxiety. And both depression and anxiety within pregnancy are suggested to increase the risk for adverse pregnancy and birth outcomes, ranging from things like preterm birth to postpartum depression. And what really sparked my interest in this project was that often episodes of depression and anxiety within pregnancy are actually preceded by earlier episodes within adolescence and young adulthood. So really stressing the importance of the preconception period within mental health in understanding how depression and anxiety works within pregnancy. And so when we think about characterizing depression and anxiety, particularly within population-based administrative data sets, which is primarily what I work with perinatal populations, we tend to use pretty simplistic and dichotomous definitions. So we ask questions like, did the individual have depression or anxiety during pregnancy, yes or no? Did they have a history of depression and anxiety before pregnancy, yes or no? But we're a bit better within non-perinatal populations with recognizing kind of the heterogeneity within depression and anxiety. So we think about what subtype the mental health condition is, what the patient's background is, what the nature of their care regimen looks like. So are they seeing a therapist? Are they taking psychotropic medication? Are they potentially seeing a psychiatrist? Or are they just seeing a general practitioner? And we also think about what point in the treatment they're at. So are they at the acute phase, so actively managing an episode, or are they in the maintenance phase? So working on maintaining their current mental status, potentially between episodes, or trying to prevent the next episode from occurring. And so that kind of guided our research questions for this project. So we wanted to see if we could more precisely classify exposure to mental health disorders within pregnancy. And then we wanted to see if this approach could improve our predictive models for pregnancy and birth outcomes. So to give you a little idea of what the study design looked like, in our first objective, we really were focused on operationalizing variables. So we operationalized that binary variable that I talked about. So depression and or anxiety within a given period, yes or no. And then we also operationalized variables that were more detailed and focused on describing the timing, the severity, the frequency of care, and the persistence of depression and anxiety within pregnancy and before pregnancy. And then within our second objective, we focused on predictive modeling with those variables, looking at predicting outcomes of interest such as postpartum depression and preterm birth. And then we compared those models with various statistical techniques that I won't get into too much detail here with, but I'm happy to answer questions about it. And so kind of moving into what we found, we did find some fairly interesting results. So with the addition of binary variables that described whether or not an individual had depression or anxiety within a preconception period or the pregnancy period, we actually saw the greatest improvement with just the addition of a yes or no variable for the 0 to 1 year preconception period. And we did see significant improvements up to 5 years preconception. But that effect attenuated as we moved backwards in time. In terms of our detailed variables, we saw the greatest improvement with the addition of a variable describing whether or not an individual had seen a psychiatrist within a given period, and then followed by a variable that described the persistence or the chronicity of the depression or anxiety prior to pregnancy. And then following adjustment, we were actually able to improve our balanced accuracy from 62.6% to about 69%. And we did actually see the most significant improvement in our models with the addition of our mental health history variables. And just to give you a little bit of a summary of what we found overall, I didn't go into the preterm birth models, but I'm happy to discuss those as well. Just in the interest of time, I wanted to focus on the postpartum depression example. But we did find that more nuanced definitions of depression or anxiety can be used within population-based data, and that including data up to 5 years preconception improved predictions for both preterm birth and postpartum depression. And the utility of the variables that we included really depended on the outcome of interest. So including a variable that described psychiatry visits helped more with our postpartum depression models, where including a variable that described outpatient visit frequency helped most with our preterm birth models. And these are my references for the first part. And then I'm happy to take any questions.
Thanks, Grace. I know I've seen part of that presentation, or I've seen that presentation before, but it's just such great work, really interesting. All right, does anyone have any questions at all?
Yeah, I thought it was a great presentation, Grace, and really interesting work. I was just wondering if you had any thoughts on what could be behind, the improvement in the model for the preterm birth, specifically about outpatient visits.
Yeah. So I'm definitely really curious about that, because I think that the like outpatient visit frequency, I think that could be reporting on severity, but it could also be reporting on like the continuity of the care and like how often they're coming in to see their physician to be treated for their mental health condition. I think that without exploring it more in depth, I can't really say for sure why the outpatient visit frequency helped the most, but in general, the association was a lot weaker, and that particular variable did offer a bit more information about what their health service use looked like, which could have some sort of association with their health conditions outside of mental health potentially, but definitely something that would be cool to explore further.
Anyone else? You can just unmute yourself or type it in the chat. No more brave souls. So I guess one thing I was just wondering, Grace, was about, so since that year before seems to be so predictive, like having some sort of screening in place seems like would be a pretty, like, kind of that next step in terms of like an intervention. Do you know if anything like that's being done already, or it's just sort of up to the, individual GP or?
Yeah, I mean, I think that's definitely where things are headed. Like, I think that it's becoming more and more supported that we can't just focus on what mental health looks like within pregnancy. Like, we have to be thinking about what mental health looks like beforehand as well, because that's highly predictive of what mental health might look like within pregnancy. And it's also really challenging to make those changes within such a short time span. And so I think that those interventions are definitely the most helpful. As to whether or not like that is like the most predictive, it could be a factor of just there being more information, I think, for most of the individuals within the study within that year. And so there's a bit more like discrimination between like each individual and like how predictive that particular variable is. Yeah, but I think just having some intervention that occurs like beforehand and having support for mental health just throughout reproductive age is just going to be like really important for trying to mitigate the effects of mental health disorders on pregnancy and birth outcomes for sure.
Awesome. Any other last questions? No? You just did such a good job explaining everything. No one has questions. All right. Well, thank you so much, everyone, for joining today. I will just do a brief call. We do these, I don't know, we did, I think 3 last year. We'll probably do another one getting closer to summer, but we do them about quarterly. So if anyone is interested in sharing their work, as you've seen today, you can, even if your research is more in a planned state, it's still a great place to share your preliminary plans and get feedback. So please do reach out if it's something you're interested in. We're also happy to have people who come back later on with later results. So yeah, spread the word if you or anyone in your labs is interested in presenting at the next one. We haven't like picked a date or anything. We usually go based on just the presenters' availability. So, but yeah, I'd really like to thank all of our speakers. Those were wonderful presentations today. And with that, we'll give everyone 8 minutes back of their day. Thank you so much.